Okay, so if you all remember, I think the first slide Jake said was that surgery alone isn't going to help treat these tumors. So I'm going to introduce you now to Jennifer Johnson, and she's going to talk about clinical trials in treating primary brain tumors. Thank you.
I'm delighted to be here. Thank you so much for having me. I really am constantly humbled by the shoes to fill and the tradition at UCSF in the world of neuro-oncology. When I would say to people, "Oh, I'm moving," why? And I was like, because UCSF is the mothership of neuro-oncology, and so I'm delighted to be here and want to say thank you so much. Neuro-oncology is a labor of love. It requires relentless, sometimes pathologic optimism, in that we firmly believe we can make a difference for our patients. When people will say to me, "Isn't your job sad? Isn't it depressing?" And I say it's frequently sad because we get attached and we want to help people, but it's rarely depressing because one of the gifts of the nursing role is that there's always something you can do to make something better. And so I am gifted with that every day of being able to come home and be like, well, maybe it was a small thing. My patient pooped. Small to me is big to a patient in that situation. So I'm very, I find joy in my work, and I was made for this. So I am really happy to be here. I'm also humbled by Jake's lecture, and neuro-oncology is such a small world. It's such a family that literally in our conversation turns out that he is close friends with an undergrad of one of the trainees at MD Anderson. Just kind of very small world. So it's all connected. Oh, this patient's going to go here and get treated by this person. Oh, great. Well, we know them. And oh, I know this nurse who went on and became a nurse practitioner. And, it's such a small world. My cousin and her husband, he was diagnosed with a glioblastoma at the very beginning of the pandemic. They lived in Boston. We were scared when he went into the hospital that he would get discharged and he wouldn't be able to get back in. So we were ready, mobilized everything to bring him to Texas. Then he, through the tiny world of neuro-oncology, managed to get treated by Patrick Wen. And unfortunately, he died after about a year. But his wife has now, based on working with Dr. Wen's team and his very famous nurse practitioner, Chrissy, has decided to go back to grad school. And so she was formerly a lawyer and now is becoming a nurse practitioner with 3 kids at home. I don't know, but she is doing this. And so it's just the sort of thing that when you wonder if it has meaning, it does. And it's a joyful profession, though sometimes sad. So I'm not going to be quite as technical as Jake. There is an art to nursing, but I want to just talk a little bit about some basics of clinical trials and some unique challenges in primary brain tumor treatment. We'll talk about some novel therapeutic directions, and then we'll do some Q&A. So one of the things that to me is important in talking about glioblastomas is recognizing a few things that are really highlight why it's difficult to do clinical trials in this setting. Number one, it's quite rare overall, about the 8th most common cancer. If you take all of the malignant brain tumors, it's pretty hard for patients to understand the distinguishing factors between a malignant and a non-malignant brain tumor. There's always that patient who has meningioma and they're told it's benign. It comes back. And then 5 years into it, you're like, no, this is cancer. And they're like, what? No one told me. And it's like, so thinking about what is cancer is important. And some of the things that make it really challenging to understand our statistics is that there is a natural history to lower grade brain tumors that over time, even with the best treatment and the best care, they tend to accelerate in their clinical behavior. And what started as a lower grade tumor, if it's in the astrocytic lineage, will almost always end up as a glioblastoma if the patient lives long enough. And that given the difficulties in studying these patients, some of the things that Jake has described, that doing these supramaximal resections may make your patient live longer, but if the functional debility kind of counteracts that benefit, and that we always are afraid of patients losing what makes them fundamentally human. And then also along with that is that it's hard to know exactly what's happening with these patients. There are limitations to the quality of our tools. There was a time when literally what what neuro-oncologists did a pneumocephalogram. They injected some air and watched where the bubbles went. One of the ways that is not what we have to do now. So when we're trying to explain to patients, well, MRI is the best tool we have, but it's a representation of what's happening in your brain. It's not what's happening in your brain. And that a lot of these statistics will go back to earlier times. Also complicating factors is that prior to the 2021 WHO reclassification of pathology, we would see this sort of small numbers of glioblastoma patients who lived an extremely long time, and you kind of, why is it that two people with the same diagnosis can do so differently? And we are now learning to molecularly define these. And so what was a glioblastoma in 1996 is maybe not a glioblastoma now. You'll have that patient who's like, oh, I was diagnosed in 1996 with a glioblastoma. And I'm like, today we would not call that a glioblastoma, but good. And so it's very difficult too to integrate these changes in schema, changes in technology with what this really means longitudinally for our patients. What you thought you had this and now you have that is a bridge that's hard to follow. That's a bridge that's hard to understand for people. And even for us. So moving on a bit, talking about clinical trial terminology, patients correctly, I think, have a reasonable suspicion of being in a clinical trial. There are patients who will come to you and say, I want the newest thing, the latest and greatest thing, and no matter what, I want what's tried and true is not for me. And at the other end of the spectrum is, I am not a number, you are not experimenting on me. And every phase in between, depending on where the patient is in their journey, what their clinical picture is, what they're actually capable of doing, both physically, financially, from a family perspective. And it's always a bit of a moving target. One of the things that I really do want to address is the common fear amongst patients that they will get a placebo and not know it. So there are cancer trials that do use a placebo-controlled trials. These are typically like population-based longitudinal studies of is doing something now or something later better. And patients who enter those trials are restricted to patients who can be followed longitudinally. So I had a patient once who was a 20-year-old girl who had the first reported ectopic ependymoma. So it wasn't in her brain, even though it should only be as something that grows and lives only in the brain. It was in her bladder. And we had to convince the urologic surgeons to do surgery on her because in ependymoma, the extent of resection is closely aligned with the survivorship. And to say to them, well, you have to do this surgery. We're asking you to do a surgery on a 19-year-old girl, that it was invasive into the bladder. She had to sacrifice her ovaries and fallopian tubes. She had an ileostomy. She was a Division I college athlete. And we went to their tumor board to present, and they pull up their life charts for the other cases of, okay, well, if you look at the actuarial tables, if we take this person's prostate out now, they will live to be 95.2 years old. And if we take it out in a year, they'll live to be 96.3 years old. And we're like, and our study was tiny. It was 100,000 patients. And we're like, we have one patient in this situation in the world, and trying to figure out how to distinguish between those things. So a patient who's going to live to be 96, if you take it out now or take it out later, who's able to be followed, is a completely different animal than a brain tumor patient. So even in our, what we would sort of in shorthand in the clinic say, this is a placebo-controlled trial, it's typically standard of care plus a placebo. Can we enhance what we're doing? And that's typically in the phase 3 setting. So the analogy for the trial that we have had recently open was the de novo trial, which basically takes what's considered the standard of care, the STUP trial, and then adds another drug to see if we can benefit. So everybody's getting treatment. Some patients are getting a placebo in addition. Some patients are getting the study compound in addition. So because it would be unethical to deprive a patient of treatment in that situation. So we would never do that. So it's a little bit difficult in our setting to say, how are we going to do this? So a phase 0 trial is drug developmental only. This is typically preclinical. There are some small centers that do phase 0 trials. They are few and far between. They require intense safety monitoring. And if there is a therapeutic benefit, it is a bonus for the patient. The trial design is literally not to find, is this therapeutic? Phase 1 trials are similar. You classically think of this as a first-in-human trial. So typically has been given in the animal model. These are typically very small numbers of patients. So in the single digits and the low single digits. There was a clinical trial recently that was actually a phase 2 trial, but run out of a phase 1 group called the ROAR trial. This is a trial that led to the FDA pan-tumor indication. It's what was called a basket trial, and there were 13 glioblastoma patients in it, later expanded for the 3% of glioblastoma patients that have a BRAF mutation, which was originally found in melanoma, repurposing melanoma drugs in this setting. So we're talking about extremely small numbers of patients, but based on that, there's now an FDA approval for those 2 drugs in the recurrent glioblastoma setting, which is new in the last 6 months. And so it's really small numbers of patients. It's very challenging to enroll enough patients to make a statistical difference or to move the needle. Not that there aren't individual patients who benefit, but knowing also that about 95% of clinical trials in the cancer setting are negative trials showing no benefit for the therapeutic intervention. You have to be relentlessly optimistic that the next thing that you do is going to make a difference, and that the care of that patient makes a difference, and that you have to be able to follow patients closely and take good care of them to manage their medical problems. Patients often don't understand why. Oh, I have these significant medical comorbidities. Why am I not a candidate for this clinical trial? Well, in some cases, we literally don't know what it's going to do. And if you're extremely sick and practically bedridden, at risk of complications of immobility, which in and of itself has very high morbidity and mortality. Patients, for instance, who get devastating spinal cord injuries, high spinal cord injuries, and are stuck in bed, they have something like a 70% 1-year mortality. So just the complications of being a very debilitated patient is what can preclude you from clinical trials, and that is for the patient's own safety. So it's very difficult to balance moving the science forward, which in theory every patient should be a clinical trial patient, if you're solely looking at the science with the well-being of the patient in front of you. So these are some of the challenges that we face. In phase 3 trials is typically when you're trying to redefine the standard of care. So in glioblastoma, there's one single treatment that's been proven across all comers essentially to prolong life, and that is sometimes called the STOOP trial, named after the leading author, and that is maximal safe resection followed by 6 weeks of concurrent chemoradiation. And then the clinical trial was 12 months of adjuvant temozolomide. Subsequent studies have suggested that 6 months is enough, and that's what most people are treating now, that there's not a marginal benefit to the 12 months. And these trials also will confirm the efficacy of phase 2 results. So there's, what's the adage, many a slit between the lip and the sip and the lip. So many phase 2 trials, unfortunately, when you do a confirmatory phase 3, rolling it out to a larger audience, unfortunately don't show a benefit. Countless examples of that. We often will treat off phase 2 trials. And there's also a difficulty from a drug development standpoint with small numbers of patients. Is a drug company going to sponsor a study with small numbers of patients to get a compound to market? The amount of money that it takes is really extensive, because going from phase 0 to phase 2 and phase 3 is potentially millions of dollars and years of research. And then in phase 4 studies, these are typically post-marketing studies. Something has hit the market. The classic example for this is if everyone has known someone who had a statin and they decided they weren't going to take it because they got body aches. Right. So in phase 4, post-marketing is when rhabdomyolysis as a statin-induced complication came to market, that there were random patients complaining of muscle aches. It's actually pretty statistically rare, a few percentages of patients, and for the majority of patients, the benefits far outweigh the theoretical problems, but added a level of monitoring in that now people typically will follow liver function tests, recheck after a month after going on a statin to ensure safety in that very rare complication. This is also relevant for, in particular, immunotherapy. So if you look at the immune checkpoint inhibitors, of which there's about 6 on the market now, the things that are very rare and catastrophic in less than single-digit numbers of patients, typically the polymyositis and the cardiomyositis, myasthenia, these very rare things, you wouldn't see until you gave these drugs to thousands and thousands of patients. So there were patient deaths, but because the clinical trials, each arm may have had 300 or 400 patients in a large study, because it's statistically so rare, you won't see this side effect until you see large numbers of studies. And you always have to be pretty lively and aware of the unintended consequences of clinical trials. So if you have ever known someone who took Rebastio for pulmonary hypertension, that drug was created to treat pulmonary hypertension. In the original clinical trials, it was not successful. The dosing was off. But what happened, this is an Eli Lilly drug, and in the clinical trials, gave the drug to a gajillion people, and how they figured out who was getting the placebo and who wasn't was at the end they try to collect the specimens back, right? They collect the unused drug, and it turns out that there was all the men didn't want to give the unused drug back, and it turns out at the dose that they were giving it was now what became the Cialis dose. So they got a little smarter, they revisited, and lo and behold, now Ravagio is a life-changing treatment for pulmonary hypertension. So there are lots of studies out there where you think that you have a failure, and turns out you have a success two ways. So bonus. So that's a win-win for the drug company and for the patients as well. In terms of some more terminology, standard of care, this is more of a legal term than a medical term. So legally, it's what the reasonable person would do at any point in time. If you're a patient and you come to your doctor and they say to you, okay, this is what we think we need to do. We're going to send you to see this surgeon, and they're brilliant, and they're going to do this, and then we're going to do this radiation, and we're going to give you concurrent chemoradiation. And the patients will say to you, well, I'm not standard. I don't want standard of care. Okay, how do you address that? And that is something that people hear all the time. No single patient is standard. First of all, we tailor every step of the treatment is tailored to how you are and where you are. But what I try to say from a medical standpoint to patients is this is the best known therapy. And the reason that we offer this to the majority of patients in absence of a clinical trial is because it's the one thing that we can really say, it's been studied extensively in thousands of patients. We understand the side effects. Yes, it's not perfect. We're trying to better it. But at this stage of the game, it's the best thing at this point in time for you. And in the heme space and in other disease spaces where they do actually have very large randomized phase 3 trials comparing X to Y, trying to better, the standard of care therapy is actually referred to as best supportive therapy. So that's something that, like, I remember in lymphoma when I worked in lymphoma, having patients go, oh, well, I don't want R-CHOP. Well, R-CHOP is just the standard of care. It's been the standard of care for 20 years because it's excellent, right? And same thing has happened that over time, we have learned how to better that in select cases, but there are still a significant number, about 80% of patients with that disease who are cured. So I try to talk about it in that setting. There is no standard of care in glioblastoma, no set second line therapy, whereas in breast cancer, it's quite algorithmic. There's a gajillion patients. Okay, if we do this, and then this, and then this, and then this, there's 96.2% chance that you're going to be cured. And it's actually, there's enough patients that you can actually plug it into a calculator. Or in colorectal cancer, it's right-sided tumor versus left-sided tumor have a completely different prognosis. We don't have that level of data because we have such a small number of patients. So what I try to think about for patients is did the results generalize? Okay, so we have a clinical trial that had 13 patients, one patient did extremely well. Okay, so what does that mean for you as a patient, right? Does it generalize to you? Do you match that patient? Did that patient respond for reasons that are unclear? Are there sufficient patients to have real results, right? Okay, there were 12 patients, one patient responded. What does that mean? Well, these patients were probably cherry-picked. They were perfect. They had no other medical problems. What does that mean in the real world? And almost always real-world data is not quite as robust as the clinical trial results. And are the results clinically meaningful? So you'll see this a lot where, okay, there was a trial that was technically a positive trial. It was statistically significant. The patient lived 3 weeks longer. What that 3 weeks was in the hospital, they were transfusion dependent. So taking the time to talk to a patient and say, this is what this really means to you as a person. We can do this. The question is, should we do this? And these are very nuanced conversations that are difficult to have, but important to have. And also balancing that with, I've had patients that, okay, they were young and they had young kids and every day mattered. My cousin and her husband were those. Every day mattered. 3 days before he died, he would still only eat sugar-free Jell-O because he thought it would make an important difference to him. And his wife was very wise, and she said, that's totally fine. She was hiding and eating cake, but in the car in Boston in the winter. So, and are the results meaningful? What's valuable to the patient? So these are really important conversations that, yes, to move the science forward, every patient, every time, but in the real world, that's not always what matters. So in terms of clinical trials, levels of evidence also matters. The plural, one of my jokes is that the plural of anecdotes is not data. So those people on Facebook who their gardener sold them some lawn clippings and their friend's third cousin once removed made a tea and they did great. okay, that's not the same as a clinical trial, right? So, and then patients will often say to you, that's data. I was like, well, it's a big question of how do we know anything, right? So the gold standard for creating, for leveling up in clinical trials is a randomized controlled trial, blinded. We don't always have that. We can't always get that for practical reasons, but important to think about. There's something called the law of large numbers. So the more patients there are in a trial, the more likely it is to give us a true result. We don't get large numbers in our patients, right? And so it's very, very difficult to reach these levels of evidence. And we are often needing to treat patients on a lower level of evidence. So there's many a time that we will say there were small numbers of patients in a phase 2 trial who benefited. And then you start thinking about balancing risk and harm. Okay, well, what's the risk of harm if we do this when there's not great evidence? And then balancing those things per patient. So, skepticism of new things is not new. So I think we've all run into people who would not accept something that's novel. For me, this was a really good cartoon. So this is from 1802. These are patients who thought this was a reprint from a newspaper in 1802. Patients were refusing to get the cowpox vaccine, that was the smallpox vaccine, because they thought it was going to turn them into a cow. So, the government nanobots are not in our brain from our COVID vaccine. But bad science does harm, and I specifically picked this because it's relevant now with so many people who are skeptical about getting COVID vaccines. So we've all heard about patients or people who are reluctant to give vaccines to their children over autism fears. The physician who led what was supposed to be a clinical trial lost his medical license in Britain. There were 12 children. He was completely unethical. He was taking blood from kids at from people at his children's birthday party and paying the children for their blood specimens. So bad science does long-lasting harm. Very few people, I think, actually know the data behind this. It wasn't data, and so we have to balance being aggressive with also being safe and having rigorous science and making sure that first and foremost is the patient in front of us every time. All right, so unique challenges in treating brain tumors. So glioblastoma is a whole brain disease. This goes back to some of Jake's slides. It's a neurologic disease in addition to being a brain tumor. So we can control the cancer, but unlike other diseases, patients don't recover from that completely. They still have sometimes devastating neurologic changes, whether they're personality or functional changes or cognitive changes. This took me a very long time to get my mind around. Somebody, their MRI looks better. Why aren't they better? Because in my setting of multiple years in inpatient lymphoma, leukemia, heme, melanoma, and I have done crazy things in the service of melanoma patients before there were any clinical trials. I have put IL-2 in every body cavity you can think of. This is not a thing that you should be doing. And why isn't the patient getting better? Okay. Also, glioblastomas are very heterogeneous. So unlike, say, a B-cell lymphoma, where it's actually a clone. It's an overgrowth of multiple identical cells. So it's having resistance is actually a little bit more rare. They're very responsive to treatment. Even within the glioblastoma, they're different. And this is a challenge in solid tumors in general, and why you'll sometimes see these discordant responses. One area of the tumor got better, one didn't. Well, it's because they're actually biologically different. Finding effective drugs is a problem. It's a unique cancer. It's a rare cancer. Drugs that spare the healthy brain, right? Killing brain cells is actually not a humongous problem for humanity. We're pretty good at that. But killing only the cells that we want to kill is a tremendous challenge. Overcoming the blood-brain barrier and minimizing long-term toxicity. There is some inherent toxicity and debility that goes with the diagnosis itself. And then studying effects in the patients. In other cancers, it's literally like, well, let's just stick a needle in it and see what's going on. And in lung cancer, this is very prevalent. It's actually standard of care to rebiopsy a lung cancer patient if they have had prior targeted therapy to find what the resistance mechanisms are and to select the next therapy. Well, it's a lot different to do a fine needle or a core needle biopsy of a lymph node than it is to take somebody to the OR and do a brain biopsy, right? The inherent risk in that is very, very high, and you can't really convince people to do that on an ongoing basis. There are limitations to diagnostic imaging, so and the minimally invasive techniques are difficult. So these are big areas of study. I am relentlessly optimistic, though. So brain tumors is where I think it's at. I wanted to just refresh us on the blood-brain barrier. I found this quite endearing. This highlights some of the challenges.
Welcome to 2-Minute Neuroscience, where I simplistically explain
why
neuroscience
it's so hard to
topics
get
in 2
drugs where
minutes
they
or
need
less.
to be. And this is,
In
I think,
installment,
understandable
I
for
will discuss
patients.
the blood-brain barrier.
The blood-brain barrier is a complex that surrounds most of the blood vessels in the brain. It acts as a barrier between the bloodstream and the extracellular space of the brain, allowing only certain substances like water, oxygen, and small lipid-soluble substances to easily cross from the blood into the brain. This prevents toxins, pathogens, and other potentially dangerous substances from crossing from the circulatory system into the brain. It is thought that the central components of the structure of the blood-brain barrier are the tight junctions of endothelial cells, the cells that make up the interior surface of blood vessels. In other blood vessels throughout the body, there are small spaces between these endothelial cells. Small blood-borne substances can pass through these spaces and into surrounding tissues. The endothelial cells that make up the blood-brain barrier, however, are fused tightly together to form tight junctions that restrict diffusion across the blood vessel lining. Glial cells called astrocytes also have projections called astrocytic end feet that extend to the walls of blood vessels that are part of the blood-brain barrier. Astrocytic end feet often completely surround blood vessels in the brain and are thought to play critical roles in the formation of the blood-brain barrier. For example, they seem to be involved with signaling that prompts endothelial cells to form the tight junctions necessary to create the blood-brain barrier, and they are believed to have multiple functions involving the maintenance and regulation of the blood-brain barrier. The blood-brain barrier protects most of the blood vessels in the brain, but there are some areas that lack a blood-brain barrier, allowing substances to pass from the circulatory system to the brain and back. For example, the circumventricular organs are a group of structures lacking a blood-brain barrier that are centered around the ventricles of the brain. These structures are thought to be lacking a blood-brain barrier because their functions require access to the bloodstream. The posterior pituitary gland, for example, has to be able to release hormones directly into the bloodstream.
All right. So the blood-brain barrier I think of as a frenemy in the brain tumor patient. We need it because it keeps undesirable things out, but we also hate it because it makes it difficult for us to get therapeutic targets in. So moving on to a little bit more novel approaches, overcoming the blood-brain barrier. So a few things that from a practical standpoint make the blood-brain barrier difficult to circumvent. You need tiny molecules to get in. So most of the targeted therapies are too large. So you need a very small molecule. The newer generations are smaller and more elegant, ideally lipophilic. Those tend to be bigger. And so we're looking at some less invasive ways to circumvent this blood-brain barrier selectively and transiently, because if you open it and leave it open forever, you have a whole new set of problems. One of my standard jokes with patients is, we don't need any new problems. So there are a variety of technologies out there. One is called the SonoCloud. We have this coming into trials soon. It basically, you do a neurosurgery, you put a small patch that has an array, and you literally plug almost like accessing a Meyer reservoir, if anyone's ever seen that done. You have a small probe, you plug it in, and it sends cavitating tiny little bubbles in. The patients apparently love it. Apparently it makes them feel quite euphoric, but it only lasts for a bit. And so you can see these microbubbles. You actually do this live in an MRI. And so you can actually watch the blood-brain barrier opening in real-time fashion. So we have logistical problems with opening these trials because there's some concerns of the safety of the patient, but this is a transient opening, and you can actually see the cavitation. And the benefit of this is that you can take drugs. In the clinical trial, the drug that was used was carboplatin because it was well known to have efficacy in glioblastoma. The problem is getting it in a concentration in the brain that's not too toxic in the body. So you could actually give carboplatin in a more conventional dose, i.e. area under the curve dosing 4 or 5, even lower in some cases, the area of the curve of 1 in some studies, and still see benefit, still see penetration of the blood-brain barrier. And you could give actually repeated frequent dosing instead of the sort of every 3 or every 4 week. You could give sort of almost metronomic dosing, low dose, frequently hitting this over and over without the systemic toxicity. So, and you open the blood-brain barrier proximal to the tumor, so it does have some problems in terms of treating the entire brain component, but it's pretty neat. This is a company called Incytec. So this is something that Dr. Berger has been involved with, and this is pretty neat. using focused ultrasound, using 5-ALA as tumoricidal. So they actually use focused ultrasound to light it up, the 5-ALA. They actually give it IV in this study. And you just do repeated treatments. We'll see how that works in the real world, but it's novel, and the 5-ALA is not systemically toxic that we know of, so that should be good. And then the other one, that minimally invasive technique, it involves laser interstitial thermal therapy. So there are two companies that make this minimally invasive thermal probe, and essentially what the procedure is that you make basically a burr hole, the same as you would with a craniotomy, and you feed the thermal catheter in. This is also something that's being used in epilepsy. It's a little bit more fleshed out there. It's nice because it's pretty focal and does spare a patient open surgery, and it would be considered a cytoreductive technique as opposed to surgery for these sort of deep tumors. And there is some thought that it also opens the blood-brain barrier. So there have been a couple clinical trials where sort of within the post-lit window, you give chemotherapy in the salvage setting and maybe you get some efficacy there. So there's a lot coming that is a little bit less risky and debilitating for the patient. There's some special challenges to this. For the MRI typically looks kind of terrible right after the first couple MRIs after the procedure. It looks kind of awful, very inflamed, and so it's tempting to abandon things, and patients typically need steroids, but typically for most patients, one night in the hospital. Talking about additional novel therapies. So CAR T is basically a lab-grown, maximally personalized therapy. This is pretty well fleshed out in the hematology population, not so well fleshed out in other solid tumors. Is actively under study, also at UCSF. There's some clinical challenges to this. So essentially, it works most obviously in a very homogeneous population, because literally what you do is engineer an antibody that's attached to a CAR T cell and expanded in the lab, grow thousands of these, and then they are targeted at one thing. So when you have a very heterogeneous tumor cell population, you have trouble because it won't necessarily work for everyone. There are also some time constraints because it takes about 6 weeks in most cases to manufacture the personalized approach. And basically you spin off white blood cells, you select them, you grow them in the lab, you expand them. Sometimes they don't grow, and then you infuse them back into the patient in sort of the heme and solid tumor model. Then we have these questions with the blood-brain barrier, and are these CAR T cells actually going to get where they need to be? Because the blood-brain barrier is intended to keep out inflammatory molecules, and these are bigger than regular white blood cells. So there's a lot of technical aspects to this that we haven't fleshed out, but having seen the effect of this in heme patients, it's really exciting, but we have to be very careful. And the other thing about these is there's a relatively high incidence of something called, the one that's most worrisome for the primary brain tumor patients is CRS, which is a neurologic cytokine release syndrome that causes sometimes coma and death. So that doesn't help patients get better. And there are reversal agents that can be used, but typically you're really worried because you've gone through all of this and then you turn off the efficacy of the agent. So it's always a big question of balancing risk and harm. There is always a patient for this, but we need to figure out the safety first. And then another big idea, this is a therapy that's actively being used.
The ultimate unknown, besides space travel, is understanding.
Actively being used for Alzheimer's therapy, and we have some of the same challenges, right? It's really hard to know what's actually happening in the brain in an Alzheimer's patient. Really hard to get therapeutic targets. The patients are so debilitated that it can be hard to know what's going on with them and what they're experiencing. So there's a novel therapeutic that is also being pretty well fleshed out. There are several HER2-directed therapies that we do know have CNS activity in brain metastases from breast cancer, also in lung cancer. There's one called sacituzumab vedotin, and this is basically pairing a drug with an antibody, marrying them up, and delivering them to the tissue of origin. So some of the same problems here. These are bigger. They do tend to have a lot of cytokine release,
brain.
which is
It
tied
is
to their
the most
mechanism of
complex
action.
organ in the human body and probably the most complex
But I really liked
on
this.
Earth. There are 100 billion neurons in each of our brains, which is equivalent to the number of stars in the Milky Way. And there are 500 trillion connections in a single human brain. It's really the great unknown. I, as a neuroscientist, want to treat neurodegenerative diseases, and Mark's world is therapeutic antibody development. We focus on a single molecule and how it may be playing a role in disease in the human brain. But because of this barrier between the brain and the
love
rest of
this.
the body, we
This
were
is what I
limited in
think
our
of when I think of the
ability to
blood-brain
get
barrier.
antibodies into the brain.
The blood-brain barrier is a significant challenge because antibodies and most molecules don't cross. Right. And so we were looking for some approach where you could piggyback on nature's systems to get our drug into the brain.
The problem is that no one's been able to do it in a setting that is really reasonable for developing a drug. The analogy that I like to use, being a skier, is it's like a ski lift.
The ski lift is the receptor or the pathway that we're trying to utilize to get molecules from the blood into the brain. It's always churning, going up and down the hill, right? And then you have molecules in the blood, which are essentially the skiers at the bottom of the hill. And the way that people previously had looked at this was they had very few skiers. And so in order for those skiers to get on the lift, they had to bind to that lift pretty tightly. But they were just getting stuck going around and around. And they never get into the brain. So the problem was, how do you get them to get off at the top? We realized that in a therapeutic setting, you're going to have a lot of skiers. And because you're going to have a lot of skiers, they don't have to be as fond of the lift. They just have to have a weak affinity, a little bit of encouragement to get on. And then when it got up to the top, they would fall off and be up at the top of the hill.
And that was a big idea.
I don't think this kind of work could have been done in other places in the world. It was the resources.
That is, I mean, a lot of this is PR, right? That this is directed at patient-facing or investor-facing, but we have a partnership with drug companies that we need because it's very expensive, and they also are often very innovative. You know, it's literally a smart person with an idea can make all the difference, and our job is to keep the patients going the best possible way they can so that we can actually take on and be more innovative and use our relentless optimism that things are going to get better. And they do every day. So even though
The ultimate unknown, besides
our last level 1 approved evidence, randomized clinical trial, blah, 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 was in 2005. Despite that, our patients are living longer. If you're looking at the data, they're living longer, they're living better. Even without major breakthroughs that have made it to large numbers of patients, we're doing a better job. And it's the people in this room that is doing that. It's the care we take of the patients. It's what we bring to the table. It's surgery. It's post-surgical outcomes. It's radiation oncologists. It's nurses helping the patients understand what they need to get through and keeping them going. So I just want to keep those curves moving up. And maybe we'll get to the point where suddenly there's a therapy that changes the game. Just from my background, I started working in lymphoma in 2007. In 2006 was when there was an FDA approval of a drug named rituximab. It was the first monoclonal antibody. And at that time, lymphoma was defined in the pre and post Rituxan era as a curable and incurable disease. I was working in melanoma in 2010 and 2011 when the BRAF and MEK combination was FDA approved, and when ipilimumab made it to the first patients, and those went from it's been nice knowing you to we've got a real shot here. And now behind the scenes and in the halls and in the workrooms and in the labs, people are saying we may be able to cure melanoma, right? So it's going to happen. We just have to keep going. And we have to be innovative, and we have to be brave, and we have to be optimistic. So that's what I have.